Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine. Welcome to Moving Medicine, a podcast by the American Medical Association. In today's episode, AMA President Dr. Bobby Mukkamala and panelists take their discussion further and talk about how key state-level issues like prior authorization and scope of practice impact patients and physicians, and how the AMA is advocating alongside organizations at the state level to address these issues. Panelists include AMA senior attorneys Daniel Blaney-Cohn, Kimberly Horvath, and Emily Carroll. If you missed part 1, you'll want to go back and give it a listen. Here's Dr. Mukkamala.
So, as is the case with nearly all of our advocacy, these issues impact more than just physicians, right? The consequence of this, the most important consequence is that on patients. And so, can you guys talk a little bit about how your team works with other organizations and why this is important? Daniel, you want to go first?
Yeah, other organizations are key. We want to build as much support for the work that we do as possible. And I want to emphasize, another thing that, physicians don't work in hypothetical situations, right? The patient that had stage 2, unfortunately, grew to stage 2 tonsillectomy. That patient didn't need a hypothetical care. The same way that other organizations need to understand that we're not just doing this for the sake of policy. We're doing this because it has real patient impacts. So, for example, other organizations that people on the call probably have never heard of, but groups like the National for Wellness Issues, groups like the Federation of State Medical Boards. They're the national governing association for every state medical board. The AMA and the Federation of State Medical Boards, we're on the exact same page when it comes to physician wellness issues. And we want every state medical board to adopt these best practices. So we work directly with the FSMB to go ahead and make presentations, to put articles together. People may or may not see them. So we work with other organizations, such as the Joint Commission. Anybody who's involved, any physician on the call probably has heard of the Joint Commission. You may have heard of other alphabet soup kind of groups like NCQA or URAC. These are credentialing verification organizations. They agree with our recommendations. And so when we do advocacy to state legislatures and state regulators, and we have the support of these other organizations, it lends credibility to the solution. Because ultimately the solutions are those that directly help patients. And in the physician wellness case, it directly supports physicians getting care. The top reasons physicians tell us that they don't receive care is because their fear that it's going to have professional repercussions. Physicians fear that disclosure of past treatment of a mental illness when there is no current impairment is going to be an anchor on their career. They're going to be judged by their colleagues. And so we want to remove as many barriers as possible so that physicians can get care if they need care. And these other organizations, we know that they talk to people in places that we don't go to. And so that's why we work with all of these alphabet soup kind of organizations to go ahead and build as broad a coalition as possible.
Thanks, Daniel. Emily, as it comes to prior authorization, tell us about who else we work with to try to accomplish that, because the consequence is so high for our patients.
Yeah, absolutely. I mean, on the issue of prior authorization, I think the biggest pain point for physicians is the harm it has on their patients and the intrusion that prior authorization has in the patient-physician relationship. So there's just a natural synergy with so many of the national patient organizations, and we work really closely with them. I think all the reforms I kind of mentioned earlier, you can see their theme is, relieving some of that patient harm. So this has kind of led to the formation of some really successful collaborations between state medical associations and patient organizations, the local chapters of some of these national groups. And we've spent a lot of time here at the AMA over the last several years meeting with the national patient organizations, listening to their concerns on the issue of prior authorization, kind of vetting some of our solutions and ensuring that, making sure that we're aligned wherever we can be. And so we've helped kind of create a framework here at the AMA that we can then, as a state medical association decides to take up the issue of prior authorization reform, we can kind of then help say, okay, these are the organizations that are looking to be active on this issue. Let's activate, either a formal coalition, which several states over the last couple of years have done, and created, websites with patient organizations, and really shown to legislators how widespread the problem is and how much impact it has on the patient community. And then we also have states that work very informally with the patient coalitions, whether it's doing just a sign-on letter or something like that. But it really, I think that relationship with the patient and consumer organizations over the years has really led to successful reforms. I can't even think of legislation that has passed in the last several years where it hasn't been part of a joint effort between the State Medical Association and the physicians and the patient groups. So really critical relationship there.
Thanks, Emily. And Kim, any thoughts about how, beyond physicians, other groups that help with our scope of practice efforts?
Yeah, again, scope is a little bit different here, right? Physicians are often the leading voice in opposing inappropriate scope expansions. But I will say that the patient perspective, and it's good that I'm going after Emily, because the patient perspective is really critically important. And so we do bring that perspective into our advocacy, and we can do this through some of the survey work that we've done. We've interviewed and done a number of national surveys of voters and patients across the country. And from those, we know that patients want and expect physicians leading the healthcare team. And we also know from those that they want physicians being involved in the medical diagnosis and treatment decisions for their healthcare. So we make sure that lawmakers know this as well. So that's one way that we do this. We also make sure that patients are informed. And so that's another kind of angle of our campaign is, there's a lot of different healthcare professionals. So Daniel mentioned an alphabet soup. There's an alphabet soup, right? A lot of different healthcare professionals. And it can be incredibly confusing to patients, especially, in a hospital setting or somewhere where they're not actually making an appointment and know who they're going to see, but where they have different healthcare professionals coming into their room. And whether they're the patient themselves or a member of the patient's family, just having the information and feeling empowered to ask, somebody walks in with a white lab coat and or scrubs are you my surgeon? Are you an anesthesiologist? Are you a nurse anesthetist, a physician assistant, nurse practitioner? Who are you? What member of the healthcare team, right? And so just kind of giving information, empowering them to feel like they can ask that question. And then what does that response, then what does that mean? What is the difference in education and training, for example? And so that's another aspect of the work that we do, is just kind of patient education and making sure that they feel empowered to kind of ask questions and have the information at their fingertips.
Yeah, and I'll just mention, this is kind of the oddest example of working with another organization, but when we had a potential expansion to independent nurse practitioner work here in Michigan, it was a nurse practitioner that then became a doctor that came to talk about why it was that she pursued this career and why, looking back on it, there's no way she would function independently, right? And so it was, technically she was in our group, but before she was in our group of physicians, she was in those people that we were having a conflict with about taking care of patients. And then she's the one that basically said, I'm glad I became a physician because now I can take care of my patients better independently. So the next question I'll ask, Emily, I know that you all also spend a great deal of time working with national policy making organizations to try and bring attention to some of our advocacy goals. So why is that important, Emily?
Well, I think they're just a critical piece of the puzzle here. And as we work with sort of these national policymaking organizations, we kind of plant seeds that help feed into the state level activity, kind of best ideas, best practices that we share with these groups. Often these national policymaking organizations may develop model legislation or model regulation. And so we try and influence that activity so that when it makes it into the individual states, it contains some of our policies and positions. For our state health insurance work, groups that represent interested legislators, like the National Conference of Insurance Legislators and the National Conference of State Legislators, are really important organizations for us to work with. We regularly attend their meetings, offer presentations, share resources with this group, with these groups. And then also, sort of in this health insurance space, the National Association of Insurance Commissioners plays a big role in insurance policy. Insurance regulators, they not only implement and enforce the laws that we're talking about passing here today on health insurance, but they also are involved in the development of legislation, and often in the states. The NAIC develops its own model legislation and model rules, and they really, they offer model bulletins. So, and we work really hard to sort of influence the activity there, so that when those models come to the states, they're really reflective of our work and of our priorities. So, and I know Daniel works with a lot of these groups too.
Yeah, so Daniel, speaking of regulators, I know that you are working hard to impact regulations related to physician wellness. So can you talk to us more about that interaction?
Yeah, so I mentioned earlier, we've gone from about 20 states that have removed invasive questions to now we're at about 34 states that have removed. That means we're getting there. I don't do math very well. I'm a lawyer, but I think that means we only have about like 15 or 16 states to go. This is something that doesn't necessarily require legislation, but it requires commitment. And so, we can't necessarily advocate for for regulatory boards to show the commitment to their licensees to support physician health. So that's why we work with, two important groups. I mentioned the Federation of State Medical Boards, critical partner, the Federation of State Physician Health Programs, another critical partner. But one of the most powerful groups that we've developed a really close relationship with is the Dr. Lorna Breen Heroes Foundation. And some people on the call might know who they are, but this is a foundation that was started, by the tragedy that was the tragedy during the early days of COVID, when Dr. Lorna Breen, an emergency medicine physician in New York, died by suicide. And as a result of all of the stress and burnout, and she didn't feel like she could get help. And so it's remarkable what's happened with the Breen Foundation, where we work together to talk directly to medical boards. We ask medical boards, and this is something that still blows me away. We ask medical boards to share their licensing applications with us, and many have, but some don't. Some don't want to do that. And so with another one of our colleagues in the Advocacy Resource Center, we sent FOIA requests to those boards to get the applications so we could do direct advocacy. Now, some of the medical boards, I'll say, Dr. Mukkamala, they didn't appreciate the AMA's direct advocacy to stop asking questions that were stigmatizing about mental health and substance use disorders. But the AMA continues to ask those questions. We work behind the scenes. We don't call anybody out, for doing this, but we want all of the regulatory boards to meet the same consistent national best practices that support physicians from getting the care they need when they want to receive it. And at the same time, balance that with their statutory obligations to protect patient safety. And so, like I said, 34 have done it. The 16 or so that haven't done it, we want to work with them. They know that they need to do it. And so we're going to continue to work with them until every state in the country has met that national best practice consistency standard.
Thank you. So, Kim, what wins have you seen in these areas, and are you seeing that these wins are shifting conversation happening in other states?
Yeah. So, in terms of the wins this year, it is still early. I'm a little superstitious, and I don't like to count anything as a victory, especially in the scope of practice space, because obviously we're either trying to defeat bills or amend legislation. So don't like to count anything as a win until that last gavel has been struck and the session is officially over. But we are seeing some good trends so far this year. And I think really it is a testament to the work of the people that we get to work with and have the privilege to work with every day at the State Medical Association. Their lobbyists, their government affairs staff are amazing. But it's also the physicians who take the time out of their busy schedule to talk to lawmakers, especially if a vote is coming up for a bill is coming up for an important vote, or they're going down to the Capitol to talk with them or testifying on a specific bill. All of that is really important. And so I think that is the key to kind of ongoing success. And from a overarching level, the work that the team here at the AMA does, and the AMA as a whole, I think we have been overarchingly successful. And just if I can point to a number from last year, we had over 200 victories at the state level. And again, this is working hand in hand with our colleagues at the state level, but on all of the issues that we work on, over 200 victories. So it is we continue to work on these issues, but there are significant victories along the way.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
Thank you. I'm going to skip ahead just to make sure we get to cover enough questions, but you've all been working on these issues relentlessly year after year to get these wins in any given year. And it's not about sending one letter or partnering with one organization or reaching the finish line and then we're done. It's not a victory that it's like permanent. And so in advocacy, there's always more progress to be made. And the AMA has been at the forefront of this, advocating on behalf of patients and physicians. So can you tell us about playing the long game, right? Is there anything strategically that we should do to not just win this single thing, but the entire thing? So Emily, what are your thoughts about the 1 year victory versus changing the trend so the next generation of physicians and the next generation of patients have a safer, better place to practice and to be taken care of?
Yeah, it's such an important point, Dr. Mukkamala, and I think one that we have to remember sometimes ourselves, that we have to play the long game. Even in the states where things might happen a little bit faster than they happen in DC, it can take years to really lay the groundwork for reform, build those coalitions we've been talking about, educate lawmakers, get the language right. When I started working on prior authorization reform many, many years ago, what legislators really wanted to talk about was a standardized form. So, standardizing the question set, which is a great solution, but it wasn't a comprehensive solution, right? And it's they didn't understand what prior authorization was. Patients didn't understand why they weren't getting their care. And so the education that had to be done, the storytelling that had to happen, the connecting the dots between one person's personal experience with a health insurer and the need for systematic reform, that had to be done and that had to be discussed, and that takes time. So obviously, as a result of all of the hard work of the state medical associations, I think we're now in a place where we're talking about volume reduction. We're talking about continuity of care, qualified reviewers, timely responses, and meaningful, comprehensive reform. And groups are working that into their agendas, as we discussed. And sometimes that progress isn't totally quantifiable. You can't necessarily measure it as an obvious win, but I think it's progress nevertheless. And like you said, it's really important that we're playing that long game.
Thanks, Emily. Daniel, any thoughts about the long game as it relates to physician wellness? How do we get it to be an environment that physicians are happy to practice in? My mom's a retired pediatrician. She worked until she couldn't work anymore, right? There was never a burnout cause for her to even think about stopping her practice. How do we go backwards to that time where physicians work until they just can't work anymore, as opposed to, I got to get out early?
Yeah, that's a great question, and I'm glad you followed your mom's footsteps there, Dr. Mukkamala. I think the long game, we we have these legislative wins, and then for for the wins, then they have to be implemented. So the regulatory agencies need to do more work. And we work at, Emily mentioned, the National Association of Insurance Commissioners. I work with regulatory boards. We work with a number of others, but we work closely with the regulatory agencies to actually implement the laws. These laws don't enforce themselves. And so we want to then go ahead and have these regulatory agencies and others actually communicate what the laws do. We find in the wellness area, just because a group removes, or a hospital, health system, or state removes these questions from applications, that doesn't mean anybody knows about it. I'll give you one story. There's a large health system in your state, Dr. Mukkamala. They were one of the first that we worked with. And everybody in the C-suite worked really hard, and we were all on the right page. And then they found out, like a month later, that they forgot to tell the IT people to actually make the change. And so when they realized that, they were like, they got taken care of pretty quickly. But if you don't tell anybody about the win, you don't tell anybody about it, or the regulator doesn't actually enforce the law, then the effects can be much more limited. So the long game also involves enforcement in many cases, and it involves communication. And so those are some other areas that we take advantage of in the long game. And the other thing is awareness. Emily and Kim both talked about that. Everybody's very aware of these issues. And with physician wellness and these work on credentialing applications and questions and removing stigmatizing language, even though the Americans with Disabilities Act has been around for a long time, nobody really applied it in this manner as it goes to licensing questions. And so we take a look not only at what the requirements are, but we have to make sure that everybody is aware of how to implement that and make changes. And that takes the awareness and communications, takes a little bit more time, but that's what we also do. Dr. Mukkamala, let me turn the tables a little bit on you. As a physician advocate, you have been active. Certainly, you've been active with the AMA, but you've testified and had meetings in state legislature in Michigan. Can you tell us a little bit about what you have learned and the resources and other things that you've done at the state level, and how you've worked with your state medical society that that can sort of shine a light on what just us lawyers are talking about here?
Sure. Yeah. I mean, I can't even count how many times I've heard in my 25 years of practice and advocacy work where a lawmaker has said, when we go there to testify, that we've never heard from many doctors on this issue, right? Like it's the first time they're hearing from. And sometimes I think that's just the way they sort of try to wiggle between two different opinions. But sometimes it's a reality. And it was just so frustrating because I knew that we contacted many of them. But if it didn't stand out from their perspective, I have to think that they heard a lot from those on the other side of any particular issue, right? So whether that was an insurance company, whether that was a non-physician healthcare provider. And so for those reasons, I think that, physician advocacy is critical. As frustrating as it is to see, for example, in Michigan, my home state, in my practice, there were 2 times that we convinced the lawmakers that, if we're going to put somebody to sleep, if I'm going to put a kid to sleep to deal with their airway issue, I want an anesthesiologist available and not just a nurse anesthetist. And 2 times, the lawmakers 100% agreed, and they insisted that anesthesiologists be part of that anesthesia team. The 3rd time it came up, we lost. And now we have independent function of nurse anesthetist. The science didn't change, right? But it's just who they hear from. And it's a new group of lawmakers. So 3 different sort of classes of lawmakers over the course of the past 25 years. The first 2 classes decided that, this is important. We need to maintain physicians' presence there. And then the 3rd class that happened to have 3 nurses within that class of lawmakers decided that it wasn't something that was critical. And so, I think it's important to share the stories of what prior authorization is like, what it does to my patients with the head and neck cancer, so they can hear from physicians what it's like in our operating rooms, what it's like in our offices taking care of patients. It's critical that we present that to them, because that's where the rubber meets the road, right? And the more we can take it down from a theoretical academic conversation to this is what's happening to your constituents, to our patients, to our neighbors, I think that's when they start to listen. So it looks like we've got just about 10 minutes left. And so why don't we go to questions, guys? I'll read them to you, and then we'll either assign them or so. This one looks like maybe Daniel first. So in addition to prior authorization and the Wellness Act, please address what the AMA is doing to combat attacks on truth, vaccines, and other important public health issues. What else can we do at the state level? Because this is a critical issue for physicians and our well-being, knowing that we know the science, but being confronted with these headwinds. How do we help physicians take better care of their patients because of this?
Yeah, I'd say for the start, public health issues, handled by, another one of our colleagues here. I work a lot on mental health and substance use disorder issues as well. And one of the things that we talk to our state medical societies and other partners about is we always want to highlight the research. We always want to highlight the science. I think you made a great point, Dr. Mukkamala, that the science hasn't changed. And so when it comes to, substance use disorders or the treatment of opioid use disorder, we want to make sure that we're using the best evidence-based science. One of the things that Emily and I work on together is removing prior authorization for medications for opioid use disorder. The evidence is clear that MOUD is the gold standard of treatment. And, one of the, if there is prior authorization of that at the pharmacy counter, there's a chance that patient will leave the pharmacy counter, potentially use again because they didn't get their medication, and potentially die. So we highlight what the real life consequences are and that's just one important public health issue. And by staying true to what the science is and being clear about what the science is, that's how we address at least that one aspect of it. And I'd encourage everybody. The AMA has, you know this better than I do, Dr. Mukkamala, but the AMA has been very clear about our support for a wide range of public health issues. I wouldn't pretend that the AMA website is always easy to navigate, but the issues are there and they're clear about AMA support for those issues. And so I would say rely on the information from trusted organizations, like the AMA, to provide that information back to state legislatures.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
Thanks, and I'll just mention a little thing that I've learned, and that there's so much on the AMA website. To find a particular answer to a question is somewhat difficult, but that's where a Google search or an internet search really comes in handy. Like if you type in AMA in prior authorization, you'll see all sorts of our content that come up that way, right? So not having to navigate through our website, but going and clicking something right on the internet search that will take you right there.
Yeah, Dr. Mukkamala, I might also say every state medical association and every state medical society knows how to get a hold of the three of us. Mm-hmm. There are now at this point in our careers, I won't age any of us, but we've all been here a while. Physicians know how to get a hold of us, and we're always available to talk to medical societies, to talk to individual physicians, to talk to medical students. We do it on a daily basis. So if there's ever any question on these issues, just call us. We're happy to talk with you.
Thanks, Daniel. Emily, a couple of questions. One might be a quick answer, and that is, will the prior authorization resource that you mentioned be posted? And then also, what state strategies have been undertaken regarding pharmacy benefit managers, if anything, at the state level?
Great. Yeah, and the resources, absolutely. And good. This gives me a good opportunity to shout out our fixpriorauth.org microsite, which is a great grassroots resource. You can share your stories there. You can access all these resources and more. And our colleagues in our Administrative Simplifications Initiatives Department do an awesome job of putting all that information out. And I would direct you also to the recently released prior authorization physician survey, which is a great resource for some of this legislative work. It really shows the patient harm of prior authorization, the physician harm, and the sort of systematic harm of prior authorization with some really good data points. So encourage folks to go to fixpriorauth.org. And then on the PBM stuff, I think that was the next question. Mm-hmm. I think we are very engaged in PBM activity, certainly sort of related to prior authorization. We make sure in our model legislation, which serves as the basis for a lot of the state activity, that we are not just targeting health insurers, but that the reforms that are included in it include utilization management entities. So that would include a PBM or any other benefit manager that really focuses on utilization review. So kind of reforms in the clinical space, the clinical decision-making space there. Then we also work really closely at NAIC to monitor their work on PBMs and engage whenever possible. We have a great drug price transparency model bill that Daniel has put together that is out there and available. And then we do a lot of work with patient organizations on issues kind of PBM adjacent, like copay accumulators and other things like that, where we feel there are some real PBM problems. So lots of kind of work in different spaces on PBMs for sure.
Thanks, Emily. Kim, what actions are the AMA taking to ensure that patient safety is maintained in the midst of non-physician practice scope expansion? How do we make our argument in state capitals about patient safety when there's a look at expansion of non-physicians doing that work?
Yeah, so patient safety is at the cornerstone of everything we do and kind of trying to defeat these scope expansion bills. We do have a ton of resources, whether it's issue briefs or GeoMap series or what have you, summarizing research and data on this topic and really including the importance of patient safety. And I think those are available to our colleagues at the state level. And there are a number of these are available on our website as well. But it's the why we're working so hard, right, to defeat these. And I think it also why we, as I talked about earlier, we also try to educate patients because we think it's important that they understand these issues as well as patients themselves, and make sure that they are well informed about who is providing their health care.
Thanks, Kim. How about we do one more question and then we'll wrap it up. Emily, we've had trouble at the state level with prior authorization because state legislators have said that they're waiting for federal reform. And so the question is, the statement is we do need both state and federal work on this, but what about the trouble when you're at the state level and the state lawmakers are saying, you know what, we're going to wait for the feds?
Yeah, absolutely. We've heard this a lot over the last couple of years, and we're so lucky that our federal colleagues have been able to accomplish some huge successes at the federal level to address a number of the markets, including Medicare Advantage, some QHPs on federally facilitated exchanges, Medicaid. So there's been some great progress at the federal level, but the state reform is absolutely needed. There's a huge chunk of state regulated plans that need to be at a minimum brought up to the federal floor, and if not, go beyond that. And I'll say the federal progress is very reflective of all the work the state medical associations have done over the years. All those reforms that we saw in those two new rules were successes that had happened in the states over the years. So that state activity is so critical, both from a top-down and a bottom-up kind of approach. As I mentioned, we have that one resource, and I'm happy to make sure that gets out to folks that shows what has been done at the federal level and where states can build on it and why it's so important that they do. So we will make sure that gets shared out.
Awesome. Thanks for those details, Emily.
Yeah.
And thank you to our panelists for joining us today and helping us take better care of our patients. The AMA Advocacy Resource Center on our website is the place to find these resources the data points, model legislation. This is not a wheel that has to be reinvented 50 times in 50 states. The white papers and a host of other materials to support you in our advocacy efforts at home. And so I hope you take advantage of these amazing resources. So thank you so much for participating today. Appreciate it.
This has been Moving Medicine, a podcast by the American Medical Association. Subscribe today to never miss an episode. Thanks for listening. Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.